Thank you very much for the introduction, and let me just say thank you very much for the invitation, because I'm stunned of the quality and of the participation of this meeting. Let's try to give some insight of this topic that is for sure not easy. The presenter before me already said a lot about calcium, and I think that it adds a little bit of information when the calcium is not on the artery but is beside the stent. There is something that is really, really nasty. So first, let me introduce the enemy that we have to face. This is a typical case that happens luckily no more than 5 or 6 times per year, but anyway, when it happens, it's a really difficult situation. We are talking about a patient with effort angina and with already implanted a 1.5-year-old verulimum stent that was a 3/0/15 implanted in the mid RCA, and the final report of the PCI, the basal PCI, said with minimal residual stenosis, less than 20%, but to be honest, probably the situation was already like this at the end of the basal procedure, the index procedure. So in another center, they tried to reopen up this stent, and you can see here with an ampullus left, they tried to force the stent with semi-compliant balloons and non-compliant balloons, but still the stent was not expanding, even pushing up to 3.25 balloon at high atmosphere. So they decided to stop the procedure for safety issues and to send the patient in our center to further treatment. And now that we know the enemy, we can discuss about a little bit about why this stent is not opening up. So, in fact, we know that stent failure is not super common, luckily, not so much, and it's the incidence of stent failure is decreasing over time, but anyway, still it's a big problem because it can happen with restenosis, that is a relatively benign situation like this, but also with stent thrombosis that is really dangerous for the patient. And we know that stent undersizing and stent underexpansions are one of the main determinants of stent failure over time. So this is the situation when we need to clarify what is happening into the stent. And in fact, all the guidelines that we have, the European were updated last year, but anyway, the use of imaging while you're doing a stent failure is strongly encouraged, and it makes easier to understand what is going on. So in fact, IVUS or OCT are almost the same in this situation. We know that OCT are better for some type of situation like calcium, for understanding the thickness of calcium, whatever. But anyway, in this situation, when the stent failure is present, using OCT or IVUS is more or less the same. So in fact, what we need to know from intravascular imaging are these 4 information. First, the type or the characteristic of ISR, so in-stent restenosis, that may be focal, diffuse, or proliferative. We know that also angiography can give us this information, but angiography for sure cannot give us the morphology of what is happening inside the stent. So hyperplasia versus atherosclerosis versus calcific atherosclerosis. And the third point that is really important is to understand if we have also a problem of stent sizing, stent expansion, or even strength factor. The fourth information is the size of the stent, or even better, the size of the vessel in order to carry on a good treatment. We also have this classification, and also a classification is really useful because it offers not only a classification but also some information in order to choose the best strategy to treat every type of stent failure. And based on this classification, I show you some examples. We can have mechanical stent failure. That means that you can have underexpansion or undersizing, as you can see here in the left panel, or stent fracture. That is not always easy to be seen at intravascular imaging, but you can also see by stent enhancement or angiography. Or you can have biologic stent failure. That means that you have a restenosis based on hyperplasia, based on neoatherosclerosis, or the worst scenario, based on calcific neoatherosclerosis. This is the worst. Plus, obviously, we can also have mixed mechanism or multi-layer restenosis that we know that are the worst scenario, the worst possible scenario. So, in fact, in our case, I spent 5 slides to say that IVUS or imaging is essential. IVUS was not crossing. So, as Ziad said before me, when you are in this situation where your IVUS is not crossing at all, or your imaging modality is not crossing at all, it's better to go on with the PCI without some information and take what you have. And in this case, what we had was this stent enhancement that showed that for sure the main mechanism related to this stent failure were probably stent under expansion or calcific neoatherosclerosis. So we tried to select the modality of treatment that can offer the treatment for both of these situations, and we started doing ROTA. So, in fact, ROTA was not crossing, like IVUS was not, probably because a non-super favorable angle. It was a 1.5 burr, we tried 180, we tried 200, but was not crossing at all. So we restarted the procedure since the beginning, so from the beginning, and we put a more supportive setting with a bigger catheter and a guiding catheter extension, and we started ballooning once again the lesion. So we started with small balloon, intermediate balloon, non-compliant balloon, up to 4.0, but you can see here that even 4.0 non-compliant balloon inflated up to 24-26 atmosphere were not able to crack the calcium underneath the stent. And let me show this, that is really impressive. It's the stent boost, the stent enhancement that shows that was really a dog boning of the balloon inside the stent, and we were not able to crack it. So next step, I think that you know which can be the solution in these cases, because we also have some evidences. We went with IVL. IVL inside stents is something that has good evidences, let me say. Probably the most evidences of the device are about in-stent or stent failure as compared to native coronary arteries. But anyway, the evidences about this use of IVL are pretty strong. So we went with 4.0 IVL. We gave everything that we had at the time, 80 pulses, because it was the first generation device, so the second generation device. And then once again, we went with 4.0 non-compliant. And probably what we had, it was to do a good plaque modification with IVL underneath the stent, and then with non-compliant balloon, we did a good lesion prep, and then again we were able to push a little bit more with non-compliant balloons and to put a long stent in order to cover the stent that we treated. So to be honest, the evidences about using IVL inside stent failure are in favor of implanting another layer of stents, because you can ruin the polymer and the stent structure with the IVL balloon. So we decided to go with further stenting, also pushing up a little bit in the proximal portion of the artery. And this is the final result. Let me say, it's pretty satisfactory. Luckily for this patient, we also have 1 year follow-up that was scheduled just for checking what the result of this extensive stenting of the RCA was. The patient was asymptomatic. And let me say that probably at the end of the day, we won the battle against this nasty lesion behind this under-expanded stent. So, in conclusion, my final message is that for sure calcium is something that must be addressed during the first procedure, and the presenter before me showed you the best strategies: ROTA, orbital, IVL, non-compliant, cutting, scoring, OPN. We have a lot of strategies for doing a good lesion preparation at the baseline procedure. But if you are not able, stent failure will be a big pain in the neck for your daily job. Intravascular imaging is essential, but if you cannot do it, and we were not able to do it, do whatever you can, and probably balloon-based technique still are the best choice that we have in this setting. Anyway, stent ablation or even orbital ablation can be a choice. We don't have big evidences about it, but anyway, just remember that for this type of aggressive lesions, you have to be ready with aggressive therapies. Thank you very much.